Okay. So this talk is basically based on one of our recent papers where we looked at diabetes-related vascular complications in pre-diabetes. And as probably reported by a few earlier studies, we also found to our surprise that you do have a percentage of pre-diabetic individuals where what we traditionally attach to diabetes and long-term complications of diabetes were also found. And what could be the implications, what could be the possible reasons for this will be forming the course, the basic uh, gist of my talk for the next 15 to 20 minutes. See, why do we think about pre-diabetes? This study, as we all know, it's a landmark study, the ICMR. What we see is while the prevalence of diabetes is 7.3%, what you can see below is that the overall prevalence of pre-diabetes in the nation is also 10.3% more than the pre-diabetes itself. And therefore, while we need to manage diabetes to prevent complications, there is a huge chunk of individuals who are pre-diabetic, traditionally are thought to only have a risk of conversion to diabetes and to some extent a risk of cardiovascular disease. But perhaps there's another reason why we need to bother about pre-diabetes. Let's see. If you go to the metros, and this was a study conducted in Delhi by us, we found that the pre-diabetic prevalence, depending on which criteria you use, was 21% or 39.5%, including IFG and IGT. So huge chunk of the population is pre-diabetic, in the metros in particular. And therefore, we do need to sit back and consider what could be the possible risk and what do we need to do at this stage itself rather than wait for diabetes to occur and then go on and on into its well-known complications. So this is just a slide to show you what we're traditionally worrying about. And probably we also need to worry about a higher risk of microvascular complications, as this talk will tell you. We've all been talking about ticking clock hypothesis, and this has been generally for macrovascular disease. And it has been traditionally believed that for microvascular complications, this is at onset of hyperglycemia, or rather at the onset of diabetes range hyperglycemia, which is being challenged by several studies across the globe. Now, looking at prevalence of complications in established or known type 2 diabetic patients, if you see, according to studies conducted in our country for the prevalence of complications, different studies, retinopathy ranges from 17 to 34%, nephropathy from 9 to 27%, neuropathy from 19 to 27%, coronary artery disease from 11.4 to 21.4%, and peripheral vascular disease from 6.3 to 28%, depending on which studies you're looking at. So you have a reasonable percentage of diabetic populations having one or the other of these complications. And this is summarized again in this slide beautifully, basically constructed by Mohan et al. And based on his study of cures, again showing basically that the cardiovascular disease is 20% or so. And if you come to retinopathy, nephropathy, again, it's about 20 to 25%. And neuropathy is closer to 20%. And PVD, as we all know, is much lower at 6.3%. So depending on which study you see, you have a fair range of complications about which we are all aware and for which we are treating our diabetic patients. If we go a little ahead and come to complications at diagnosis of diabetes, again, depending on the study that you look at, there is a range, and you can see that in this, depending on the three studies listed on the left column, the retinopathy could be ranging from, generally from 18 to 37, but one study, the HOON, shows only 1.9%, and neuropathy is 32 to 48%. Go to other studies, you have even a newly diagnosed patients of type 2 diabetes, a fair number of them already having complications, as you can see here. Retinopathy 13%, neuropathy 4%, ISD, of course, pretty high, and PVD is pretty high in this particular group. And see, so this group probably has more of macrovascular disease, but the fact remains that 33% had complications at diagnosis. And this is another study showing that newly diagnosed diabetes having a fair amount of complications and even dyslipidemia and macrovascular risk factors to the tune of 58 to 73%. And this was our own study from Dr. Aravind, the CINDI as it is called, where they showed that in newly detected diabetes, again, you have overall neuropathy 13.15%, retinopathy 6.1%, nephropathy already in 1%, and a fair number of them, over 25% or more of risk factors for you have all these complications, but the argument could well be that they were all diabetic, were not detected till they came up with complications, and therefore do not know whether this is before the onset of diabetes range hyperglycemia, or actually they were silent, they were already diabetic, and maybe even a diagnosis, they already had the complications which actually brought them to the physician. So that argument still held. And therefore, we need to look at prediabetes to answer some of these questions, whether even before the diabetes range hyperglycemia occurs, do we have a prevalence, a fair prevalence of diabetes-related vascular complications? This was one of the Australian diabetes study, first in 2002, who actually suggested that probably a pre-diabetic state also has an increased risk of microvascular complications, microalbuminuria, besides an increase for cancer. And therefore, pre-diabetes is an important concept that needs to be understood and identified even from this point of view. And now let's focus on the study that we did. This is a very recent study where we've looked at prevalence of diabetes-related vascular complications in subjects with normal glucose tolerance, pre-diabetes, newly detected diabetes, and known diabetes, and compared them. Basically, we needed about 72 cases of each of these groups, and for that we had to do about 1,300 OGTTs. And from there, we got newly detected diabetes, pre-diabetes, about half of them, and normal glucose tolerance, 657 of them. And then we took 72 NEDMs, matched them with age and sex with pre-diabetes and NGTs, and also took 80 age-sex matched known diabetes from our clinic and screened all of them for micro and macrovascular complications. And this was how we diagnosed the complications. ECG, CAD was based only on ECG or history, CV on the basis of history, PVD on the basis of ankle-brachial index, retinopathy on the basis of a fundus examination by a qualified ophthalmologist who saw all the patients, the same ophthalmologist, and nephropathy by the urine ACR, confirmed as per protocol, and neuropathy on the basis of NSS or NDS scores. And their baseline characteristics, they were matched for age and sex, but it so happened that their BMIs were more or less matched. They were not different in all these groups in the patients recruited. And the waist, except for the males, where the pre-diabetic NGTs were lower than the pre-diabetic NDDMs, the waists also happened to be not different from each other. This is the key slide, prevalence of diabetes-related vascular complications. As you could see, if you were to go from here, we have 6.3% showing macrovascular complications, but you also have 4.2% and 4.2%, although the numbers are low, but these were, the study size was calculated as per sample size calculations. So you have 4.2% of macrovascular complications, of which major part was for CAD, to some extent PVD. All in all, the complications of macrovascular disease in all the groups put together about 11 cases, 3.7% on an average. Coming to microvascular complications, again, starting with the known diabetes, you had them in 17.6% in this study in particular. You also had them in about nearly 10% of newly detected diabetes, and also nearly 7% of pre-diabetes, and about 1% could be even chance of in NGTs. But what is important to know is you have a fair number of pre-diabetics almost having similar prevalence rates of complications as a newly detected diabetic has. And if you go down these columns, you find the nephropathy was also there among the microvascular. Neuropathy is also there as part of the microvascular complications. And you also had, of course, prevalence of cardiometabolic risk factors in a fair number in all the groups, even the pre-diabetic groups and some of the NGTs as well. Not unexpected, because we are in any case a population which has predisposing factors to CAD and diabetes anyway. So you could find that in a pre-diabetes alone, hypertension was seen in 8.3% of the patients studied. Triglycerides was high in nearly 1/4, low HDL in almost 90%, and LDL cholesterol was high, and 41%, despite the fact that there were low number of smokers, overall the metabolic syndrome was also fairly high. And if you go by the metabolic syndrome features, even in the pre-diabetic group, you find that there were 3 metabolic features in 35 out of 72 and 2 metabolic syndrome features in 25 out of 72. So again, the risk factor profile wise, especially for coronary artery disease, you have a fair number of them. So what did we find in summary? Study found that vascular complications related to diabetes were present in over 10% of subjects with prediabetes. Macrovascular in 7% and microvascular in 4% roughly. What is more important is the proportion of pre-diabetic subjects with vascular complications was about half of those with known diabetes, but almost similar to those with newly detected diabetes and with no gender differences. This is the key statement. So the pre-diabetics have complication rates similar to what we find in newly detected diabetes. It could mean that lower levels of dysglycemia may also lead to vascular complications. Over 90% of pre-diabetic subjects were also observed to have one or the other risk factor for macrovascular complications, as we would expect. And therefore, the additional burden of vascular complications in subjects with prediabetes highlights the importance of initiating effective preventive measures at the stage of prediabetes itself. So we cannot remain silent. Probably we need to be more aggressive in even treating the pre-diabetic state for all the risk of complications, including now the microvascular complications that it would have. And maybe it's time to rethink about our strategies of just non-pharmacological approaches while we address pre-diabetic states. Now, if you look at what is the global scenario and some of the studies which have reported such things earlier across the globe, people have reported retinopathy in prediabetes from 7.9 to 20%, nephropathy from 15.5 to 17.7%, which is much more than what our study showed. Neuropathy in 13% of cases of IGT and 11.3% of IFG. This is the typical DPP study where, again, clearly it was shown that retinopathy is seen even in non-diabetics, particularly pre-diabetics. And in this particular study of incident retinopathy, again, even in glucose ranges, which are traditionally associated with pre-diabetic state, you find significant retinopathy. Prevalence of CKD also is found even in pre-diabetic states, as you can see here very clearly. And the association of retinopathy in albuminuria is a little different. There is a so-called cutoff effect for retinopathy after which it suddenly rises. But in the case of albuminuria, or let's say the diabetic-associated kidney disease type of a complication or microalbuminuria, the prevalence appears to be more, gradual, not a threshold type of an effect for a particular glucose value. Coming to the macrovascular disease, this is much more familiar ground. We're all aware of this slide. And we're also aware that in IGT, you have CAD, which is in the range of 14.9 to 24%, and in PVD in the range of 2.9 to 9%, depending on which study you're looking at. And therefore, this has been a traditionally known phenomenon. And the meta-analysis of 18 studies shows, again, that the risk of CVD is more, even in IFG and IGT, 1.2 times. CDC data again shows that not only you have high levels of dyslipidemia, hypertension, microalbuminuria, and also smokers, so you have cardiovascular risk factors also prevalent in this group. So there's a spectrum of cardiometabolic disease, which is a known thing, and even across IGTs you find that these predispose to type 2 diabetes as well as cardiovascular disease. So what we've actually shown from our study and the global studies across the world prior to our studies is that, you do have microvascular complications to some extent, and as we showed, almost to the extent that we see in newly detected diabetes, even in pre-diabetes. What could be the possible causes? One of our studies earlier in 2013 showed that there were abnormal glycemic profiles by CGMS in obese first-degree relatives of type 2 diabetes mellitus patients. If we look at the details of this study, it shows by using CGMS that 40% of centrally obese first-degree relatives of diabetic subjects diagnosed as prediabetes on the basis of OGTT showed significant glycemic excursion into the diabetic range. That means, although they were pre-diabetic in terms of an OGTT, actually, if you do a CGMS, you would find that, 40% in case of IGT would show glucose excursions during a 24-hour period into the diabetic range, 35% if it was an IFG, and even 15% of NGTs would show excursions into the diabetic range in a 24-hour period. So a single OGTT may or may not, in this case, may not be picking up the glycemic burden in the diabetic range. That was the conclusion. And therefore, and in fact, I'm not showing it in this slide, but for fair amounts of time, this happened as you moved up this ladder. As you were from NGT and IFG and IGT and even IGT plus IFG, you found that increasing duration of the 24-hour period, patients were or subjects were in the diabetic range, hyperglycemia. And we also label them as CGMS diabetes. It is therefore also possible that there is significant diabetic range dysglycemia in some individuals with prediabetes that results in the development of diabetic vascular complications in them. So this could be one explanation. Factors that cause glucose fluctuations, of course, under free living conditions could be many, including food intake, exercise, stress, beta cell function, insulin sensitivity, and so on, which could cause these fluctuations from time to time and from day to day into the diabetic range in cases of pre-diabetic individuals, into the pre-diabetic range in case of NGT individuals, and so on. And therefore, observations of 24 glycemic variability in non-diabetic persons become relevant and probably also could be the basis of complications seen in this group. And considerable variability of glucose levels exists even among individuals classified as not having diabetes. And whether periods of transient hyperglycemia are part of normal variability or have the potential for complications, of course, is not clear, is possible, needs long-term studies to know the true impact. Another study of interest in this context is a study which we did on PPTG responses and endothelial dysfunction in pre-diabetic first-degree relatives of patients with diabetes, and showed that both postprandial endothelial dysfunction actually increases as we move from NGT, which is group 1, to pre-diabetes without a family history of diabetes group 2, to pre-diabetes who also have a family history of diabetes group 3. So suggesting that even in pre-diabetes, you have endothelial dysfunction incrementally occurring if there's more risk. And this could affect not only large vessels, but also smaller vessels, because it's after all an endothelial dysfunction. And therefore, this may contribute to enhanced cardiovascular and long-term complication risk reported in pre-diabetic individuals. This could be another explanation. And this study, again, experimental biology 2016, showed that pre-diabetes has a toxic environment for initiation of microvascular and macrovascular complications. They explored the role of glycemia in the development, and actually it's shown that these 4 elements, which are traditionally ascribed to diabetes, increased lipolysis, insulin resistance, impaired secretion, dysregulated hepatic glucose production, also is seen to a large extent in a pre-diabetic individual, and therefore the environment for the production or the generation of complications exists in a pre-diabetic individual. And therefore, pre-diabetic risk for micro and macrovascular complications is real. So apart from the risk of type 2 diabetes mellitus and cardiovascular disease and cerebrovascular disease in a pre-diabetic individual, and of course peripheral vascular disease, I think we also need to consider a real risk of microvascular complications, which include retinopathy, neuropathy, microalbuminuria, that is kidney disease, and nephropathy. So we must become aware that pre-diabetic state can also lead to these complications, and therefore we need to start our preventive measures right at the level of pre-diabetes, whether it is aggressive treatment, whether it is aggressive lifestyle intervention, or specific interventions to prevent complications. I think the time to begin this exercise in whatever manner probably would be the pre-diabetic state itself. And we need to focus on this. Thank you very much.